present, and any two of these three constitute endometriosis. When you only see one component, for example, you see only endometrial glands, that is not enough to constitute endometriosis. Sometimes what happens is that in endometriosis can also form ovarian cysts, and sometimes you only see sheets of macrophages. So long-standing endometriosis can also destroy the pleasant presence of endometrial glands and stroma. So how does endometriosis arise? So there are basically four theories. The most common being the implantation theory or the retrograde menstruation. So retrograde menstruation is nothing, it's just a backflow of blood through the endometrial canal, because when endometrial bleeding, when menstruation takes place, the blood flows out of the cervical canal, but some amount of blood flows back. So that is called retrograde flow. So a little amount of blood can move through your fallopian tubes and enter the ovaries, or it can go into the broad ligaments and any other location. Then you have the metaplastic theory that the endometrium could arise directly from the coelomic epithelium. The coelomic epithelium, this is the epithelium from which structures develop. So some amount of coelomic epithelium cells, they remain in the ovary and they can differentiate into endometrial cells. From there, you can have abnormal bleeding, or from the Mullerian ducts themselves. So this all is occurring during embryogenic development. Now, the third theory is the metastatic theory, from which, endometriosis can spread to distant sites, for example, the cul-de-sacs and the peritoneal cavity. And this blood flows through the lymphatics and the vascular channels of the uterus. And lastly, there is one theory which is also known as the histogenic theory. It proposes that some endometrial cells are present in the peritoneum, and some cells, they're present in the peritoneum, and they differentiate into endometrial cells, and from there they can give rise to endometrial tissue. Okay, like I said, you need the presence of either two of the following three. This is very important. You need to know that either they're endometrial glands, these are normal endometrial glands, okay, and there's normal endometrial stroma and hemosiderin-laden macrophages. So either these two, endometrial glands or hemosiderin-laden macrophages, hemosiderin-laden macrophages or endometrial stroma, or endometrial glands and endometrial stroma, or endometrial stroma and hemosiderin-laden glands. Okay. In rare cases, only the stroma is identified, like I told you, because there is destruction of endometrial glands and stroma because of long-standing hemorrhage. Okay, so these are two pictures. These are two histological pictures. This is the line. This is the bowel wall. Okay, this is the full thickness of the bowel wall, and this is the colonic mucosa. And this is the submucosa, and somewhere here would be the muscle tissue. Again, this is a high power magnification of the same colonic wall. Now, this is the presence of endometrial glands and endometrial stroma in an abnormal location, which is the colon. Again, you see the presence of, very clearly, the presence of normal endometrial glands and endometrial stroma inside the colonic wall, and this constitutes endometriosis. So patient will present either with either of these following conditions. They can have severe pain, severe dysmenorrhea, dyspareunia, and one of the classic when endometriotic tissue involves the rectal wall, the classic sign is pain, severe pain on defecation in a woman. And infertility is the most dreaded complication, which occurs in 30 to 40% of the women. And yes, uncommonly, but we have seen cases in which malignancies arise in the setting of long-standing endometriosis. So this puts the patient at risk. The most common type of cancers which arise in the setting of endometriosis is clear cell carcinoma of the uterus. You can also have endometrioid carcinoma. So these are the types of cancers that can arise in a setting of long-standing endometriosis. Okay, so adenomyosis, it is just like endometriosis, but this is presence of endometrial glands and stroma inside the myometrium only. This is not the presence of endometrial glands and stroma outside the uterine cavity, but it is the presence of endometrial glands and stroma within the smooth muscle of the myometrium. Okay, so adenomyosis is okay, clinic in the books they say in 20% of the uteri, but I think it has the rate has increased. We now see approximately 40% of women who have adenomyosis in their uteri when you see that on biopsy. So again, you see irregular nests and islands of endometrial glands and stroma within. Okay, please ignore this without glands. You need to see the presence of glands in adenomyosis as well. So it is the presence of an endometrial glands and stroma within the myometrium, and it has to be separated from the stratum basalis of the endometrium. At least it should be 2 to 3 millimeters down. So superficial presence of glands and stroma in the myometrium does not constitute endometriosis. The glands need to be separated from the endometrium. See, this is myometrial tissue. You don't see normal endometrium anywhere, and these are endometrial glands and stroma present within the smooth muscle cells of the myometrium. Okay, so again, patient has menometrorrhagia, she has colicky dysmenorrhea, she has pelvic pain, she can have irregular menstrual cycles or heavy vaginal bleeding. Okay, so coming to endometrial polyps, these are masses which arise from the myometrium. They can be pedunculated, they can be round, they can be non-pedunculated as well. And basically, endometrial polyps, they're a localized form of endometrial hyperplasia. So they may be of variable sizes. They can range from 0.5 to 3 centimeters, but we have in our practice seen polyps as large as 8 to 10 centimeters. And basically they are sessile, and they cause pain and they cause heavy menstrual bleeding. So the polyps, they're basically they have a polypoidal configuration, means they have a circumscribed architecture. And you can see hyperplastic or cystically dilated endometrial glands, and they function with the cycle of the menstruation. And like I told you, they're a localized form of endometrial hyperplasia, and they respond to the growth effect of estrogen, but not progesterone. Okay, so this is an endometrial polyp. When I meant that they are polypoid or circumscribed, you see they're very round. It is a localized mass. This is a cystically dilated endometrial glands. Normally, we never see cystically dilated endometrial glands. Normally, they're more often like this shaped. And see, they're far apart. Why? Because the stroma is very cellular and fibrotic. And one of the hallmarks of a polyp is you start seeing these thick-walled hyalinized blood vessels. You cannot diagnose a polyp without the presence of these thick-walled hyalinized blood vessels. So cystically dilated glands, along with this cellular increased fibrotic stroma and hyalinized thick-walled blood vessel, constitutes the endometrial polyp. So they largely occur in postmenopausal women, but young women can also have polyps as a result of excessive estrogen. And we see adenocarcinomas arising in the background of endometrial polyps, not very uncommonly. Okay, so even endometrial polyps can occur in women who have had breast cancer, and they'll be treating with tamoxifen because it has weak estrogenic effects in the endometrium. And because of long-standing tamoxifen therapy puts the patient at risk for endometrial carcinomas as well. Okay, so these were the non-neoplastic conditions of the endometrium. There were polyps, there was adenomyosis, there was endometriosis and the theory and theories for endometriosis, and there was endometritis. Okay, coming to carcinomas or neoplastic conditions of the lower female genital tract. So carcinoma of the cervix, cervical carcinoma, it is a moderately common tumor. And the most common type of cervical carcinoma is squamous cell carcinoma, which occurs in 80% of the patients. After that, you have adenocarcinoma, and approximately 5% of the cases would be adenosquamous carcinoma and neuroendocrine carcinomas of the cervix. So there are multiple risk factors which put the patient at risk for the development of carcinoma of the cervix. And most commonly, you have long-standing infections with high-risk human papilloma viruses, most commonly 16 and 18. Okay, so 16 and 18 are the high-risk HPVs, and they are most likely to put the patient at risk for carcinoma of the cervix. Now, the papilloma virus infects the immature basal cells, which are present in the stratum basalis of the squamous epithelium, and the immature cells are present in areas of epithelial breaks, or they can also affect immature squamous cells, but they don't affect the mature cells of the cervix. They only affect the cells of the stratum basalis and the immature squamous epithelial cells. And the transition zone of the cervix means when the ectocervix is in transition with the endocervix, that point is the most common area in which carcinomas arise. HPVs cannot affect the superficial squamous cells, most likely due to the high glycogen content of these cells. So multiple risk factors are there. High parity, multiple sexual partners, these are very important risk factors. And women who do not have a high parity or multiple sexual partners, they are rarely affected by HPV. Young age at first intercourse and certain HLA subtypes. Use of oral contraceptives and nicotine puts you at a minimal risk for development of cervical carcinoma. And yes, of course, immunosuppression, because when a person is immunocompromised, she is very much at risk of contracting HPV 16 and 18. Okay, so this is a picture of the squamocolumnar junction. And in this area, there are a lot of immature squamous cells, and these have a high tendency of acquiring HPV. So this area is the most commonest site. So when this becomes very important, because when you are doing the gross cut-ups of a hysterectomy specimen, it is very crucial for the pathologist to sample the squamocolumnar junction of the cervix. It is a mandatory section, and your report will not be complete if you do not describe this area. Okay, so morphology, the gross appearance is the appearance of the tissue which you see with your naked eye. It is fungating, it is a large mass, it is ulcerating as well, and it can be infiltrating. So coming to the morphology of squamous cell carcinoma. Okay, this is a histological picture of squamous cell carcinoma. Now, squamous cell carcinoma, these are composed of large polygonal cells, and they have abundant, dense orangophilic cytoplasm and has a tendency to form keratin pearls. And many a times in well-differentiated, especially in well-differentiated squamous cell carcinoma, you do see a lot of squamous pearls, you do see a lot of keratinization, because it resembles the normal tissue exceptionally well. So if you see if you see the architecture, it has a very infiltrating pattern. This is the normal stroma, which is composed of a lot of inflammatory cells. And another feature which, because this is a low power view of the squamous cell carcinoma, is the presence of squamocolumnar junctions. So large polygonal cells, a lot of keratinization, cells having dense orangophilic or eosinophilic cytoplasm, vesicular nuclei with prominent nucleoli, Either there will be individual cell keratinization like we can see here, or there will be the formation of keratin pearls, and squamocolumnar junctions, which you see in between the individual atypical squamoid cells. Okay. So, okay, the thing I need to tell you is that squamous cell carcinoma of the cervix's morphology will be similar to the morphology of squamous cell carcinomas arising elsewhere in the body. Okay, then you have adenocarcinomas. Adenocarcinomas are characterized by proliferation of glandular epithelium. This malignant proliferation of glandular epithelium, we will not see that in squamous cell carcinomas. And these are composed of malignant endocervical cells, which are large, and they also have voluminous cytoplasm. Instead of having vesicular nuclei, they will have hyperchromatic nuclei, and in this case of the cervix, the adenocarcinomas do not readily secrete mucin, resulting in a dark appearance of the gland as compared with the normal endocervical epithelium. So if you look at this immediately on low power, we can see that this tumor is different from squamous cell carcinoma because it has a lot of glandular formations. Okay, so in this corner, we can see a normal endocervical gland. You see regularly placed basally located nuclei, and the architecture, there is no distortion, but here you see that the glands are irregular, they have infiltrating edges, they're pretty distorted. You see a lot of branching and budding, and almost here there's no intervening stroma. Okay, so no keratinization whatsoever like we saw in squamous cell carcinoma. Then you can have adenosquamous carcinomas in which you can have malignant glandular component and a malignant squamous component. Okay, so any tumor which morphologically presents with atypical glands and a lot of squamous differentiation, we put it in the category of adenosquamous carcinomas. Now, adenosquamous carcinomas are somewhat slightly more aggressive than your plain squamous cell carcinomas and adenocarcinomas. Okay. So this is a picture of an adenosquamous carcinoma. I'm recognizing this as a glandular component because the cells are more columnar, the cytoplasm is less dense, and a lot of hyperchromatic nuclei are also present, and it's a gland. I know that this is a gland because of the fact that it has lumina formation. See, this is a lumen, this is another lumen, this is another lumen. So this is a gland, this is also a gland. In fact, this is also a gland, and this is also a gland. But then you start seeing some keratinization over here. You start seeing a pearl over here. So this has both malignant squamous as well as glandular components. Neuroendocrine cervical carcinomas, these are the least common type of carcinomas arising in the cervix. They are very rare. Pure endocrine differentiation is very rare in the cervical carcinomas. Okay, so their appearance will be very similar to the small cell carcinoma of the lung. And now how you differentiate it, because in contrast to lung tumors, the cervical neuroendocrine or small cell carcinomas will usually test positive for high risk HPVs. And then there are many immunohistochemical antibodies which you can apply to the cancer cells to differentiate it from lung. For example, TTF1 is a marker which is very specific to the lung, and it will be negative in cervical neuroendocrine carcinomas. These are one of the most aggressive tumors of the body, and the prognosis is pretty poor. Okay, so this is a neuroendocrine carcinoma or small cell carcinoma of the cervix, and this is a low power view and this is a high power view. So the thing which is very striking to me in these tumors is the blue appearance of these tumors. Rather than a pinkish. This is all necrosis. Another finding which we very commonly see in neuroendocrine carcinomas of the cervix is that they have extensive necrosis. Their nuclei will be extremely hyperchromatic and angulated. See, this is forming an angle. Again, an angle is here. They will be squaring off with each other. They will be having a brisk mitotic activity. In one field, I can see 1, 2, 3, 4 mitoses in this field, and either they will have hyperchromatic nuclei. This is another high power magnification, and a feature which is very common to neuroendocrine tumors is the salt and pepper or dotted appearance of the chromatin. See? Okay, so these are extremely aggressive tumors, and because of their appearance, you have to differentiate them from polydifferentiated carcinomas as well as lymphomas. You will differentiate them from lymphomas. Obviously, you will employ a lot of immunohistochemical markers to differentiate them. But on morphology, you can know, because lymphomas will never show this salt and pepper or dotted appearance. Okay. So again, this is a revision. This is another picture of squamous cell carcinoma. You see irregular nests of tumor cells with these large polygonal cells. Here we can see a lot of keratinization. This is a keratin pearl. Again, this is a lot of dysplastic changes occurring in the epithelium, but this has invaded the underlying connective tissue and broken the basement membrane. So this has become early invasion. So this is adenocarcinoma in situ, means that there are a lot of dysplastic changes going on in the endocervical gland. This is a normal gland. This is an abnormal gland with a lot of dysplasia occurring here. They see a lot of nuclear stratification, means that the nuclei are in line with each other and they have left their basal location, which you can see here. They have assumed a more apical position. You see a lot of mitotic figures as well. And same thing is happening in this picture. A lot of nuclear stratification and hyperchromasia with the lack of mature cells present at the top. Okay, so how will the cervical carcinomas present? The most common presentation is bleeding from the cervix, ulcers in the cervix, pain on intercourse. So you need to see whether these erosions are caused by some infections or in fact they are carcinoma. So you need to do a biopsy. When a small biopsy is not sufficient, so you do a cone biopsy alone, because cone biopsy can detect microinvasive carcinomas as well. But so if the patient is positive on the cone biopsy, you need to do a radical hysterectomy with removal of the ovaries and fallopian tubes as well. And you have to do a lymph node dissection if you see palpable lymph nodes. Then for more aggressive cancers, it will all depend upon the stage of the tumor. For advanced lesions, you need to give the patient radiation as well. So the prognosis depends upon the stage of the cervical cancer. So usually stage 1A has basically the cervical carcinoma has a good prognosis. Stage 1A, 1B, and 2, they have a good prognosis. The prognosis decreases for stage 3 carcinomas. But even if you have a stage 3 or a stage 4 cancer and you irradiate the patient well, the survival can go up to around 15-20%. But if you pick up that carcinoma in an earlier stage, when it has only invaded less than half of the myometrium, or it has, even if it has invaded more than half of the myometrium, still stage 1B and 1A and 1B, stage 2, and even stage 3 have the best prognosis. Okay, so this about ends the lecture. If you have any questions, you can type them in chat. Yes, so if you don't understand anything, I'm waiting. You can type the questions on chat and I'll be happy to answer them for you. Okay, so the first question is here, why are all these lesions causing excessive pain and excessive bleeding? Why? Because any pathology which is occurring in the tissue, there is a break in the endometrium. Okay, so whenever there is a break in the endometrium and whenever there is a break in the tissue, so obviously the vascular channels are ruptured. So that's any mass. It also, for example, in the polyps, an example in the carcinomas, they are also responsive to the hormones which are released during the menstrual cycle, and they respond to them, and that's why such heavy bleeding occurs. Can you explain the stages and what are these? Stages, the extent to which the cancer has reached. For example, if you, I think that learning the stages will be pretty advanced for you at this point in MBBS, but still I will tell you, endometrioid carcinoma stage 1A is when the tumor has invaded half of the myometrium. Stage 1B becomes when it has invaded greater than half of the myometrium. Stage 2 becomes, it becomes a stage 2 when the endometrioid carcinoma has entered the cervical stroma. Stage 3 becomes either when it has invaded the ovaries. Stage 4 becomes when it has involved the uterine tissue involvement of the extra uterine tissue. For example, the tumor goes into the pelvic peritoneum or urinary bladder or rectum. Okay, can you repeat? Okay, yes, the theories of endometriosis. There are practically there are four theories actually. The most commonly accepted being the implantation theory, in which basically there is a backflow of blood, and this backflow of blood goes back through the fallopian tubes into the ovaries. So that's how endometriosis can arise. Stage 2 would, the next theory would be the metastatic theory, in which through the lymphatics and the blood vessels, the endometrial tissue goes into distant locations. The third being the metaplastic theory, in which this endometrial tissue arises from the coenomic epithelial cells present in the ovaries or fallopian tubes. The fourth being the histogenic theory, in which cells present within the peritoneum, they transform into endometrial cells. Okay. There is another question. To which cancer does the endometriosis most commonly progress? Yes, the endometriosis can progress, long-standing endometriosis, and by long-standing, I mean if you leave it untreated for around 9 to 10 years or even 15 years. So you can, clear cell carcinoma and endometrioid carcinomas are the most common carcinomas which arise in the backdrop of endometriosis. Any other questions? Any other questions or anything in the lecture which you would like me to explain again? Why only immature squamous cells are vulnerable to HPV? Because these are newly developed cells, and their glycogen content is very high, so that provides a lot of nutrition to the papilloma virus. Okay, but the mature squamous cells, they lack this glycogen content, so they are less susceptible. How do we treat endometriosis and adenomyosis? By drugs, by giving certain medications. And in endometriosis, which has gone to other side and it has caused adhesions, you need to go in and surgically remove those adhesions. Okay, you want me to summarize the cancers? Just a second. Let me see. Okay. Okay, I am going to summarize the cancers once more. Okay, so basically, yes. The most common cancers which can arise in the cervix is the squamous cell carcinoma, which is around 80%. Then you can have the 15% or approximately 15% of these carcinomas are adenocarcinomas, and the least common are adenosquamous and neuroendocrine carcinomas. Again, the cervix can also receive metastases from surrounding organs. For example, metastatic tumors from the bladder and rectum can also involve the cervix, but those are mets which the cervix is receiving from other locations. Okay, so squamous cell carcinoma is the most common, and basically this tumor, you need to remember 3 or 4 of the morphological features of squamous cell carcinoma. One, that the cells are large and polygonal. Just a second. The cells, see, you have large cells with dense eosinophilic cytoplasm, so that on low appearance, the tumor is appearing pink. Okay, so keratin pearl formation is when a lot of keratinized cells, they accumulate together, they form a sort of a keratin pearl. For example, you see that this pearl is constituting a lot of keratinized cells. For example, this is a keratinized cell, this is a keratinized cell, this is a keratinized cells. They have assumed the shape of a keratin ball. This is again a keratin pearl. This is again a keratin pearl. Again, keratin pearls you cannot see in every type of squamous cell carcinoma. Why? Because when the cells lose their differentiation, for example, when they start becoming moderately differentiated or poorly differentiated, you start seeing less and less of keratinized cells and keratin pearls. Okay, so squamous cell carcinoma is going to have large polygonal cells with abundant dense cytoplasm. The nuclei will be vesicular and they will be pleomorphic. Pleomorphic meaning they will be variable sized and shaped. And vesicular nuclei means that the chromatin will be very open. For example, this is a vesicular nucleus. I can see through it and I can see that the nucleolus is very prominent. If this nucleus was hyperchromated, I would not have been able to visualize the nucleolus. And then there are squamocolumnar junctions, which unfortunately I will not be able to show you in this micrograph. It is at a low power, but those junctions are also very common, and squamocolumnar junctions you also see in the normal epithelium. Okay, adenocarcinoma will have glands instead of keratinization. You will not see these glands in a pure squamous cell carcinoma. The glands will be irregular and they will be very dysplastic. By irregularities, I mean that they will have a lot of branching and budding, and they will be very back-to-back with little or no intervening stroma. For example, this is a small, normal-looking endocervical gland. And if you compare this gland with this gland, you see a lot of atypicalities in these glands. And again, it has the tumor has invaded the stroma. So no doubt that this is an adenocarcinoma. The third being adenosquamous carcinoma. It has both glandular as well as squamoid components. Okay, it has keratinization, it will have large polygonal cells, it will have glands as well. So when these are present in an equal ratio, you call it adenosquamous carcinoma. The thing you need to remember is that the glandular component and squamous component both will be malignant. Then you have neuroendocrine tumors. These are very aggressive tumors, and they have a very blue appearance to them at low power because of the hyperchromasia of the nuclei. The nucleoli are not as prominent as you see in adenocarcinoma and squamous carcinoma. It has a lot of mitotic figures, one over here, and these tumors have a lot of necrosis. And their nucleoli have a very dotted appearance of the chromatin, or a salt and pepper appearance of the chromatin. These tumor cells can either be arranged in sheets or they can form solid nests. And you have to differentiate these carcinomas from poorly differentiated squamous carcinomas, poorly differentiated adenocarcinomas, and lymphomas. Okay, so anything else? Okay, the thing I need to tell you is that these entities are very important You need to know some of their morphological features. You need to know their definitions. You need to know the treatment and prognosis. And we don't expect you to write long stories on the morphology, but the classic features of cancers you need to remember, like I told you. Okay. So if you do not have any more questions, I think I would like to end the lecture. अच्छा मिस अनम लेक्चर ओवर हो चुका है ठीक है मैं लॉग ऑफ हो रही हूँ थैंक यू सो मच